Hello, everyone. Before we get started with today's live event, there are a few housekeeping items to go over. Your participation is important to us, so please continue to submit your questions and or comments throughout the live event. To do so, please select the Q&A icon on the right side of your screen, type your question and or comment in the compose box where it says ask a question, and then select send. Your questions and or comments will be addressed at the end of the presentation during the question and answer time. Also, please note that this session is being recorded and will be made available for all attendees. And with that, I'd like to turn it over to Matt Wolf.
Thank you, Amy, and thank you all for taking the time to be with us today for this session, especially in the midst of the challenges you're facing. We know it, we're in there too. Staffing and provider fatigue, COVID in general, and your overall normal role as a human being. We're with you. And we appreciate the time that you're taking today to talk about the Medicaid Value Care Organization model that we are entering. And just to hit the agenda very quickly, you're going to hear about what a value care organization is. That's a good place to start. You're going to hear who SLHP or St. Luke's Health Partners is and what our role is in this whole thing, and what this arrangement means for you. And lots of resources and tools and people are going to be in this discussion that we're excited to share with you. We want your voices in this. So as Amy just mentioned, we really want to encourage questions and comments into the Q&A panel. We'll hit those at the end, and we really want to hear from you. So please be encouraged to participate that way. I think we just need to start off by talking about the why. And we do that frequently at St. Luke's, we start with why. And I think it's important to recognize why this whole Medicaid value care organization movement is important for us. You know, our mission is to improve the health of people in the communities we serve. That's really up to all of us if we're going to be successful in that. It's not just a St. Luke's thing, it's every provider in the state working together, especially when it comes to some of the most vulnerable members of our communities. We also have a responsibility to make health care more accessible and affordable. And to be very candid, the state has had an unsustainable model for supporting the Medicaid program, and that's evidenced by cost trends with double-digit increases year over year. We believe that when providers are directly accountable for clinical and financial outcomes with aligned incentives, our goals for health and affordability will be achievable for Idaho. That's specifically what this VCO model is intended to do. And SLHP has been on this value-based journey for about 5 years now, a little over that, with accountability currently for over 175,000 Idahoans. And now we're adding roughly 90,000 additional Medicaid lives from this arrangement to what we're accountable for. We have an amazing team. I love this team. We're going to introduce some of them shortly, and our resources that are available to you through this program include things like performance analytics, incentives for value-based actions, care management resources, and the team is going to go through those things in more detail throughout this session. So let me start by introducing some of the names of the folks you're going to hear today, all of which are, frankly, population health experts. And I'm excited to share the time with them and with you all. So Angelica Bennett, Dr. John Schott, Steve Drake, Julie Swearingen, Amy Gonzalez, Dr. Alejandro Necochea, and Michelle Weiss are all joining us on this session today. And we could not do any of this, even host this webinar, without Carla Burkett, Lizzie Reiser, Amy Gabrielson, and Molly Adame. We are truly excited to be working with you all on this journey, and can't wait for some of the dialogue at the end of this session. As we go through the session today, please walk away knowing that we are here and available for you to help you be as effective as possible as a partner in the SLHP Medicaid Value Care Organization. And to get this started, let's hear directly from Dr. John Schott, one of our medical directors at St. Luke's Health Partners, to share some thoughts on what this VCO thing is. So John, I'll turn it over to you.
Thanks, Matt. So to start, just to give you some background, I was born in McCall. I went to medical school in Portland and completed my residency in family practice at ISU in Pocatello. So I have some understanding of some of the communities that you are in, but I also want to share that because I think it gives you some context for some of the challenges that we want to address, or at least kind of be transparent with you that we're facing. There are really two key challenges. I think the first one is, how do we move from just being a group of people located in a building downtown Boise to somebody that you trust and somebody that you rely on as you try to figure out how to succeed in a value-based care world, not just within the VCO and not just with Medicaid, but with other payers as well. That's going to take some time. It's going to take some effort on our part to build that trust, but we're committed to that. I think that the other challenge is just the complexity of care that you all face and that your providers face. To talk a little bit more about just the challenges that we face in terms of how we work with you, if you look at the participants on the webinar today, or even the participants in the VCO, there are really two ends of the spectrum that I think that we have to work with. One group of providers are those that are part of large health systems or larger groups. If you think about those frontline providers, they may have minimal exposure to some of the details that we're talking about today. They may be shielded from some of the financial risk as well as some of the financial incentives. They may have limited knowledge about the performance metrics that we're talking about. And for all the providers, we fully recognize providers are being bombarded by different metrics from different payers and different groups. And that just makes things more complex. So with this group specifically, I think we've got to figure out how to work with you as leaders within those groups to help you strategically and efficiently address those care issues and operational issues that you need to address to make sure that you succeed. At the other end of the spectrum, there are a lot of small independent groups, and I was in practice in Baker City, which for those of you that aren't familiar with Oregon, that's about 2.5 hours kind of northwest of Boise, close to Hell's Canyon. So it was full spectrum family practice. About 12 years ago, I was sitting in a meeting very similar to this, where I was introduced to my CCO partners. And the CCO in Oregon is very similar to what we're talking about today with the VCO. And there were two owners essentially of the CCO that I worked with. One was a health system that was a national health system. It happened to own the hospital that I worked with in Baker, but I really was in many ways in competition with that health system with my clinic. I wasn't convinced that they necessarily saw the community importance of the community I was in, that there in Baker. That wasn't a focus for them. The health insurance company that was the other half of the owner for the CCO was a large payer that had a presence up and down the West Coast. Their corporate office was in Portland. They didn't know where Baker was. They didn't know my clinic. And I think it was really honestly a business proposition for them. So my motivation walking away from that meeting was pretty low in terms of initially my sense of willingness to really dedicate resources and time in my clinic to make sure that we succeeded. We've heard from many of you that what's happened over the last 3 years has been challenging. I think that the way the state handles some of the communication issues wasn't perhaps optimal. I know that many of you, quite frankly, didn't feel like you had a choice. If you want to continue to care for Medicaid patients, you had to align yourself with a VCO. Hopefully, though, you had some sense of choice in terms of what VCO you decided to participate with. And I think the one thing Matt didn't touch on is that there's not a payer involved here. That's important from a funding perspective. From where we sit, we want that money to go back to you, not to support a payer. Keeping that money as close to as possible to the care that you deliver is important to us. In terms of complexity of care, You know, if you think about a patient that may hit your clinic today with a sore throat or a sprained ankle, as it currently sits in a value-based care world, it's not enough just to follow evidence-based guidelines to take care of that sore throat or that sprained ankle. What we're asking providers to do is be aware of other issues related to that patient's care. For example, if they need a tetanus shot, get them a tetanus shot. If they need a mammogram, get that scheduled. In addition to that though, it's even more complex. I think most of you probably have heard of the social determinants of health. I think many of us are fully aware of the impacts of behavioral health and how that complicates our ability to take care of populations and patients individually. So as those patients come in trying to figure out where they're at emotionally, are they struggling with substance abuse? Are they struggling with depression? What's their housing situation like? Are those kids safe in the house? Do they have access to food? All those things are, at least in my mind, in the back of my mind when I see patients. And that, quite frankly, is overwhelming. In the clinic I currently work in, there are not resources to help me identify and deal with all of those issues, even if I do succeed in identifying them. There were a couple studies 10 or 15 years ago looking at a primary care practice, and at that time in a primary care practice, if that provider addressed every recommendation that USPTF had for an average primary care population, and if every evidence-based guideline was followed for that average typical patient panel, it would take over 17 hours a day to get through that schedule. So all of this stuff we know is not sustainable. And part of the reason I joined St. Luke's Health Partners is because the business model and payment for those services has to change. And Matt and Amy and others here at St. Luke's Health Partners, Steve Drake, have done a great job of helping to build those contracts to start that transformation. The issue then becomes, how are we going to change the clinical model? That clinical model has to change. The problem is the resources to support that work have to change with it. That's what I think we're fundamentally about. With my boss, Matt, virtually in the room, hopefully he agrees. I think our team and my job is to make sure we do everything we can to make sure you succeed in this value care arrangement. If you don't succeed, quite frankly, we aren't going to succeed. So we're fully invested in this. At the end of the day, at the end of the webinar, we need your feedback as to how we can do things better. And again, building that sense of trust and that relationship with you all is going to take some time, but again, we're fully committed to that. Getting to this slide specifically, most of the content on this slide is taken directly from verbiage that the state has produced. There's a lot of confusion about what a VCO is, and the definition I'm not going to read for you, it's right there. But basically, the VCO is the entity that's signing the agreement with the state to take accountability for a certain population. You all are participants as providers in the VCO that St. Luke's Health Partners has put together. Hopefully that will make sense, but please type in if you have any questions around that. The other goals, I think, I'm not going to read that for you as well. I think all of us have seen these goals in different presentations. And quite frankly, as a provider, the question is, what do you want me to do to make sure that this happens? Or how do I get it done? And you can go to the next slide, Molly. With our care in general, we focus, regardless of the line of business, on three things, and that's knowing the population, closing or addressing those issues that need to be closed or ordered for a specific patient, and then making sure that we do what we can to keep people out of the hospital, minimizing ER utilization, keeping them out of a situation where they need to be admitted. That's the overall goal. Knowing the population, in the literature, that the term for that is empanelment or panel management. And optimally in a primary care clinic, it would be great if all our primary care providers on a yearly basis looked at who they show within an EMR as being attributed to them. There's a lot of work in that. We know that a lot of our practices are not quite there yet. But for our VCO arrangement specifically, is part of our job to make sure that you know as a clinical entity in the VCO who you're accountable for. And that's really fundamental. If you don't do that, or you're not aware, taking any action to address those care needs or having any sense of what's happening to them in terms of the hospital is really limited. And so there's more work, there's more detail around knowing that population. If you think about it, if you're going to prioritize the scarce resources that we know all of us are facing in terms of primary care, knowing how sick they are, what their risk factors are, all of that in terms of knowing the population should help strategically identify those patients that really need those rare or scarce resources. Once that work is done, additional work, for example, building registries to make sure that those patients who have diabetes or kids who need well child exams, those kids that may otherwise fall through the cracks and not be seen, that's work that can be done once we know who a given population is attributed to. And that's some of the work that we're going to get into more detail with you today. All of that work, if we do it well, and based on our experience over the last 5 years, those clinical groups that are doing those first two things well effectively impact both emergency room and admissions in terms of utilization. So just getting them in, making sure that providers have that information and can act on it appropriately, that's the fundamental start. Next slide. So what is not changing? To start the slide, I'm going to pass it to Steve Drake, who helps us with all our contracting. And Steve, why don't you speak a little bit as to what's not changing?
Thank you, Dr. Schott, and good afternoon, all. So the, change is never easy for any of us. You're in healthcare, so you're pretty used to change because it seems like it happens in our world all the time, especially over the past year with the pandemic, year plus, continuing to this day. But looking at the new value care organization that the Idaho Department of Health and Welfare put in place beginning July 1st, we wanted to kind of assure you that some of those basic things that as a participant in the Healthy Connections program are not changing, because you really get to some of those basic elements of your interactions with patients, how you're getting referrals, how you're submitting claims and getting payment. Those are very important things to you, and they're not changing. So what is this slide kind of points out is at a high level just some of those basic things. So you continue to get your eligibility rosters, your case management payment fee that you get from the state. Those things continue to occur on the same cadence and from the same place that they do. If you're looking for referrals and patients in the Medicaid population, that was suspended for a period of time, as you're probably well aware, but July 1st, the state felt that it was appropriate to bring back referral requirements. So those are in place again now, and you follow the same process through the state as you were doing previously for this Healthy Connections population. Similarly, your claims submission and your payments that you get back from the state are coming from the same place. So you're submitting them to the same location, and the payments are coming back from the same location. And those payments are really based upon the fee schedules that are in place. Nothing that the SLHP VCO or any other VCO did to put in place impacted your fee schedules. Those all exist the same today as they have previously. So, and again, appeals and grievance, those processes that either a member may go through or you may go through as a provider, those are all unchanged through that process. So I'm going to now I turn it on over to Julie, I believe.
Before we do that, I think the other thing, just to chime in on that, Steve, from my perspective, again, as a family physician, I think our intent overall is that what doesn't change for our providers, we want them to continue to see patients and do what they can to make sure that they're providing the best care possible. And really our goal working with you is to minimize the impact to our providers. We want to do nothing but make things better. Many of you probably heard about the quadruple aim. We can't forget our providers in this and doing everything we can to make sure that, that the care they deliver is as high quality and more efficient. We want to make things better rather than make things more complicated. And we've got to have your feedback on that. And with that, I think at this point, I'll pass it over to Julie Swearingen.
Thank you, Dr. Schott and Steve. What you're seeing here on this slide is the breakup of all of our members within St. Luke's Health Partners VCO. And throughout this presentation and probably throughout our partnership, you might hear different verbiage to describe members, patients, participants. These are those people that we're accountable for within the VCO. So together, all of us make up, we have an accountability for about 90,000 lives. 3/4 of those lives are under 18 years old. So we're looking at being accountable for somewhere around 65,000 minors. As you can see, spread across the entire state of Idaho with some concentrated areas in the counties that I think we would expect: Ada, Canyon, Twin Falls, and Bonneville. The intent of this slide really is to show that we have a lot of members to care for all across the state, and it will be very important for us to work together to make sure that all these members across the state have resources. Next slide, please, Molly. Like Dr. Schott explained, these are the VCO performance measures. They tie in very well to the measures that we as St. Luke's Health Partners have been talking about for the last several years. Starting out with the population, there are a handful of measures here for the VCO that we're accountable for. Well child visits in the first 15 months, PCP visits ages 3 to 6, and PCP visits for adolescents. Closing gaps in care include diabetes A1C testing and breast cancer screening. And then finally, doing those two things very well should help us to ensure that our patients only use the emergency department when it's necessary. And should they have an admission, making sure that they have the correct discharge planning and resources when they discharge so that they don't readmit. In this case, the data that we're looking at is our baseline performance year. And just as a reminder, the performance year for the state is July through June. Next slide, please. So for that baseline year, which is July of 2018 through June of 2019, here is our overall VCO performance summary. In the blue highlighted section there, you can see our baseline score along with the state's baseline, the 90th percentile for NCQA, and where we sit currently. So the first two measures there, of course, ED per 1,000 and 30-day readmission rates, lower is better. And then the rest, the higher numbers are better. So we'll be looking to share this information consistently so that everyone in the VCO is always aware of where we sit in terms of our baseline and what our targets are for the year. Next slide, please. So finally, understanding that, that's a lot of things to process. There's a lot of things to focus on. At Health Partners, we want to make sure that you have the resources available to be able to understand your performance and any of the opportunities to allow you to succeed in these measures. So the first thing is really an aggregate performance within the VCO, and that's in our in-flight health performance dashboard. The second thing is Stellar Health, which is going to provide actionable insight for the providers in the clinics to understand which patients might need help. And then finally, our people resource, which is care management. Next slide, please, Molly. This is a screenshot of in-flight health. It shows in the same format as those outcomes that we've talked about. In the top there, wellness visit performance. So understanding your population, who you've seen year over year, and how that ties to how you're doing this year, and maybe what your wellness visit performance looks like and where you might schedule additional patients. We also show condition recapture performance, quality measures, and utilization. So this just gives you an idea of some of the resources in looking at your aggregate performance that you can expect from us at Health Partners. And with that, I'm going to pass it over to Amy Gonzalez to talk a little bit about Stellar Health.
Great, thank you, Julie. So as Julie had mentioned, as the VCO, we want to set our participating providers, you, up for success by providing you actionable insights. We want you to be able to easily identify who your member is and what value-based activities are needed. And ultimately, we want to reward you for performing those activities. To do this, we have partnered with Stellar Health. Stellar provides an online tool, fully HIPAA compliant, that directs providers and team members to perform on value-based activities and then incentivizes them with real dollars for completing those activities. Through the tool, which is illustrated here, a task is created when a value activity is required. For example, when a member needs to be scheduled for an annual wellness visit, or when a care gap needs to be closed, or maybe a prior chronic condition needs consideration for recapture. In this example, this member, Wyatt, had a previous diagnosis of diabetes that needs to be recaptured. And also he requires a diabetic eye exam. Those are the value-based activities that we are asking the teams to perform on. As activities are completed in the tool, the doer of the activity, which can be providers or other team members, are awarded Stellar Value Units, which translate into dollars. 1 unit, very simply, equals $1. In this example, that is the 20 and 10 identified next to each activity. Units, and therefore dollars, accumulate on a monthly basis, and then payments are made to each group based on the dollars that are earned. And that's Stellar. It really is not much more complicated than that. There will, of course, be more training and communication provided on the Stellar tool, how to implement and how to use. But for now, I think it's important to note that Stellar is the VCO's primary incentive mechanism for driving change in the population and rewarding you for the good work that you're doing. For this first performance year, St. Luke's Health Partners is not passing financial risk onto its participating providers, meaning you will not be held accountable to or share in financial losses or surplus of the program. The use of Stellar Health then really is a great opportunity for you to earn incentives with little risk. If the VCO does not perform well, we are not going to ask for the Stellar dollars back. This first year is focused on engagement and making available to you the tools we have put in place to help drive success. And saying that, I'd like to turn it over to Dr. Necochea and Michelle Weiss to discuss our care management program and the resources available to you.
Good afternoon, everybody. My name is Alejandro Necochea. I'm an internist. I still work as a hospitalist in the Treasure Valley. I'm also the medical director at St. Luke's Health Partners, who is supporting our care management team. And Michelle Weiss is our director of care management. And thank you. Thank you very much. Okay, so I don't need to tell you this, but the Medicaid patients that you care for, that are cared for through our VCO, can be complex. And not just from a medical perspective, but also because of coexisting behavioral health issues, or as Dr. Schott mentioned earlier today, because of gaps in social determinants of health, which unfortunately have been exacerbated in the past 18 months. To support our patients, one key capability is care management. Care management or care coordination can mean a variety of things. So here I will describe how we view the service and also describe how we will be partnering with you. Through our previous work at St. Luke's Health Partners with independent clinics, with our St. Luke's Health System clinics, and through some of the feedback that we've received from you, we're encouraged to hear that many of you already have care coordinators working in your clinics. That's fantastic. Keep up that excellent work. We also learned that what these coordinators are doing can vary from site to site. So in some cases, they are ensuring that patients receive age-appropriate preventive care and screenings. They connect patients with community resources. They help manage chronic diseases, or sometimes they manage referrals. Our approach to care management is described in this graph that you can see in the slide, and it has 3 key features. And we'll start on the top left there. And the first one is that we actually engage with patients on a longitudinal basis. And the goal is to engage with patients, develop a care plan that is centered on what their goals are, and then help them carry that plan over a period of time. The second feature is that a lot of our focus is on education, on assessment on how our patients are doing in terms of what the plan in terms of their plan. So progress towards the plan that they help craft that is focused around their goals. And the main emphasis of that is really to help patients be self-sufficient so they can manage their own conditions and they can do this by themselves with their caregivers in the future. And the third feature is that we are very focused on reducing unnecessary utilization. By helping patients develop a care plan and help them carry out that plan, our hope and what we've seen through our work over the years is that they can actually be healthier, and thereby they spend less time in healthcare buildings and more time living their lives out there. So what does it actually look like in the real world? So some of the specific activities that are carried out by our care management team include things like education around symptoms and exacerbations of chronic conditions. So for example, if they have asthma, having a plan so that when they start to feel symptoms, they know what to do, contact their primary care doctor, do this, do that, etc. Another activity is helping them navigate the complex healthcare system that we have. Sometimes they have 2 or 3 or 4 providers. They have a variety of different settings where they get their care. So how do they do that? How can they self-sufficiently manage that over time? Another thing that we do is education and encouragement to close care gaps, like certain diabetes screenings or other quality care gaps that may exist. And another key activity that we carry out is identifying barriers to achieving their plan and connect them with resources, either externally, potentially a community resource, a community partner, or internally. And along that last point, I just wanted to highlight that the care management team that we have, that Michelle Weiss leads, is a multidisciplinary team. We have a lot of nurses. It's primarily staffed by nurses, but we also have pharmacists, we have social workers, registered dietitians, we have diabetes educators, health coaches, we have a respiratory therapist, which is tremendously useful when it comes to educating patients on how to manage their symptoms and also how to use certain inhalers. We also have some community health workers, and we acknowledge that we'll probably have to grow this capability in the future. All of our engagements are remote through the phone or through apps, for example, for our health coaching activities. Next slide, please. So what can you expect from us? And the first thing is collaboration. You are taking care of the patients, and our objective is to see how we can partner so that you and your patients can have additional care management support. Next, we want to learn about each other. So we need to learn over the next several weeks what your needs are, what your capabilities are, what's worked, what hasn't worked, and also how we can work together. Our care management experience has been focused on adult Medicare populations. So to support this Medicaid population, we are working closely with our St. Luke's Children's Pediatric Care Coordination team. Many of our VCO patients are already being cared for by them. And so from that starting point, we'll refine and expand the model that can support your clinics and your patients. And last, we are very data-driven. So we use a lot of data tools to help identify high-risk patients. For example, evidence-based stratification algorithms, census information, etc. So we are going to be very data-driven, not just on the patient identification side, but also on how we're doing and what are the outcomes that we're seeing on our patients. So that is how we hope to partner with you. And remember, if you have any questions, any comments, please put them in the chat. At this point, I'll turn it back to Julie Swearingen, who is going to share when these new processes and tools will be available to you.
All right, so this is our rough estimate of what we expect to have for resources in the timeline from now until the end of the year. You know, as you can see, we didn't receive baseline data until mid-June. I understand this can be really daunting. Obviously, it's hard to perform if you don't know where your opportunities are. So it is our commitment as the SLHP team to you to be transparent and offer as much information as possible as soon as we get it. The start of the performance year was real quick right after we received that baseline data. And we do expect to start receiving monthly quality gap reports from the state later in August. We are actively working on rolling out Stellar Health starting in September. The start of our care management stratification, like Dr. Necochea talked about, we obviously have quite a bit of experience in the adult population, but we want to make sure that we really understand how best to manage the pediatric population with this. We want to be really focused on best practice and using a lot of empirical evidence to make sure that we do that correctly. We will receive aggregate baseline reports and be able to surface those in the in-flight health dashboard that I shared with you a couple slides ago. We will receive our quarterly total cost of care reports around October, and then we expect to surface patient panel details via in-flight, which is kind of an enhancement on that to allow you to understand at a higher level just what your patient panel looks like. So again, we understand that it can be difficult to know where you're at without data, so we'll continue to be as open and transparent with you as we can about how we're doing in these steps. And please feel free to reach out to any of us to request any data that we do have. It might be in a raw Excel format, but we're committed to providing you whatever we can to help answer questions about your population while we work through sort of the longer haul reports that will be available in the fall. So with that, I'm going to turn it back over to Dr. Schott.
Thank you, Julie, and thank you all for your thoughts and comments today. You know, hopefully you're getting a sense of a few things. Number one, we were really looking forward to this time with you and really appreciate, again, your attendance. We know that there are multiple things you're trying to juggle, multiple things demanding your attention. So thank you for your time. We hope this has been helpful. Invaluable. We have some time set aside to respond to some of your questions, but I think the one takeaway is hopefully from all of us, hopefully today, you've got a sense that we're committed to this. We are committed to making sure that you succeed. We've got resources. It's going to take some time, we realize, to build that relationship and that sense of trust with you all, but we'll do it. We need your feedback. Give us feedback on this webinar, but also as we move forward, please make sure that you feel like you can contact us, whether it's questions, whether it's something that you need. We want to be a resource for you. And again, if you don't succeed, we don't succeed. And so with that, Angelica, if you have questions you feel like we need to respond to, have at it.
Yeah, certainly. Thank you, Dr. Schott. We do have a few really good questions coming in. One area I would like to address first is a really good question about the sending of slides. So it's fully our intention to send both the recording and the slides out in follow-up to this webinar. In addition to that, we will resend our survey link. If you haven't completed that yet, we ask about your care coordination capabilities and resources, as Dr. Necochea had discussed, and we'd really like to learn more about your practice. So thank you for that question. The next question I would like to direct to Steve Drake. It asks about if the Medicaid patients have been informed of these changes and letting them know about the referral process being back in place, as well as the primary care provider being held accountable for care. Steve, can you address that?
Sure, thank you, Angelica. As part of the overall changes with the PCP selection and changing some of those processes and keeping members connected with the PCP for a longer period of time, the state is required to send out a notice at least 30 days before the start of this program. So by late May, early June, all members would have received a notice that they were being enrolled in the Healthy Connections program, who their PCP assignment is. I don't know, honestly, without seeing that letter, which I didn't see, how the referral component was addressed in that. I do know that through the Medicaid automated communication or customer service line that members do call into, there is automated information relative to their Healthy Connections PCP selection, as well as the referral requirements that are recorded and provided through that number. I hope that helps some.
Yes, thank you, Steve. Next, I'd like to direct a question to Dr. Schott. What happens to PCP visits between the ages of 7 to 13? And I believe this is in reference to the quality measures, not including that age range for well visit.
I'm not, Angela, can you give me a better sense of what the question is? I'm not sure I understand the question.
I would talk to the importance of wellness visits during the 7 to 13-year age range, even though it's not a part of the quality measure set for the state. So what is the expectation there?
You know, in a value-based world, if you think about the recommendations for kids in that age range, regardless of what, quite frankly, and it gets back to the earlier comment, for our providers, we want providers to continue to do the things that they know they need to do. So in that age range, to the extent that there may be immunizations that are appropriate for a given patient, if there are screenings that are due for things like behavioral health issues, we want those patients to be seen. And quite frankly, given our experience over the last 5 years, the more effective the relationship is between a PCP and their patient, the more comfortable they are with you, the more they trust you. We think that that has a direct correlation as to how they use things like the emergency room. And so bottom line is I would expect that relationship to continue. If patients are identified as needing any of those screenings or immunizations or any other gaps in care, regardless of the metrics that the state has or anybody else has, we want our providers to do the right thing and see their patients and maintain that relationship. Hopefully that helps.
Yes, thank you. Great answer. The next question is for Amy Gonzalez. The question is centered around where does the incentive money come from, and will the state reimburse less overall to pay for incentives?
Yes, that's a great question. So first, no, the state is not going to reimburse less to pay for incentives. The incentives that we will provide through Stellar Health are funded from St. Luke's Health Partners. It's our way of driving change in the population and again, rewarding you for good work. So it's something that we've taken on, and it is not related to the state's reimbursement or any funding coming from the state.
Thank you, Amy. Next is a question for Dr. Necochea. Is care management exclusive to medical and primary care, or does it include mental and behavioral health as well?
Thank you for the question. I will turf that question to Michelle Weiss, also to give her some opportunity to get in front of the group.
Thanks, Dr. Necochea. We will not be stratifying for behavioral health concerns, but we will be working with those. We have a pretty robust behavioral health team, LCSW's social work honors team, so we will help address those, especially as they relate to their medical conditions. So I guess both. We won't be stratifying for them, but we will be working with those conditions.
And Michelle, when you say the word stratifying, can you explain what that means?
Sure. So we take a lot of data. We take any clinical data that we may have. We won't have robust clinical data, especially for those VCO participants that are new to St. Luke's Health Partners. We do have some clinical data from some of our partners. We look at ADT feeds. We look at admissions from some of our community partners through Collective Medical. We also look at claims data that we get from the state. That all gets aggregated, and we look at patients' risk for admission in the next year. We look at patients' readmission risk. We look at their behavioral health risk. We also look at an end-of-life risk. So we stratify across all of those. We're looking for cost. We're trying to lower cost, getting patients into appropriate level of care. So those are the things we're looking for. Those are the gaps we're trying to close.
Thank you, Michelle.
Angelica, I will add one thing, just in case people were wondering. We actually do not have accountability for behavioral health in general, but as you all know, not all behavioral health related issues that our patients have are managed in a behavioral health environment or strictly in behavioral health settings. A lot of it is handled by our primary care teams, and that is what Michelle's team is definitely very good at supporting as well. I hope that helps clarify a little bit.
Yes, absolutely. Thank you, Dr. Necochea. Next is a question around quality and diabetic eye exams. Julie, the question is it pulled just from claims data to satisfy the measure, or is attesting to it sufficient in Stellar?
So for what we're accountable for in terms of measures from the state will have to be included on a claim. So, attesting to it in Stellar is going to give us some information to understand that, you're saying the patient did have that screening, but as far as where the state is concerned or where they have the ability to see how we're doing, it will have to be billed. So they will have to receive it on a claim.
Thank you, Julie. Next up is a comment, but I want to direct it to Steve Drake. Steve, there's a comment about making the letters available that are sent to Medicaid patients from the state to the actual provider group. Do you have commentary on how we take feedback to the state regarding these requests?
Sure. I think there's always opportunities with the state and these programs to evolve and learn a better process. And I do think they're relatively open to that, especially as they've done some of this shifting and making providers more accountable. So we'll take those comments back and figure out if there's something that we can do. I appreciate that firsthand knowledge about what has been communicated. I think they're pretty confident on the enrollment process, that you're getting that on your eligibility rosters that are coming, and that you are seeing that there, but is a little bit different than not actually having at least the format of what the letter said. So we'll look into that.
Perfect, thank you. Next, we have a question for Matt Wolf. Matt, the question is, does St. Luke's Health Partners have accountability for all of the Medicaid patients in the state of Idaho?
Thanks, Angelica. No, we do not have accountability for all of the Medicaid beneficiaries in the state. In fact, I think, somebody's going to correct me on the number, but I think there are 9 or 10 other VCOs across the state that have taken accountability for outcomes in a similar manner to how St. Luke's Health Partners is doing that. And various entities have selected to participate in different VCOs. So the conversation today is specific to the St. Luke's Health Partner VCO, and based on the lives attributed to you all as providers, that's really where the number is coming from that we're accountable for in total. The expansion population also, while we have this question, is not included in our current accountability as a VCO. I do know that the state would like in the future to include that population within the VCO program, so we can expect that in years to come. Frankly, there's just not enough data on that population to set a reasonable benchmark at this time. So we will be learning as we go with that population. We're all providing care for those individuals currently. And when the time comes, the state will, I'm sure, look for us to take accountability on value-based outcomes for that part of the population as well. And our model will be quite similar to what you're hearing about today. So we can look forward to that in the future.
Thank you, Matt. Next, we have a question regarding new enrollees with Medicaid as it relates to quality measurement. So the example that was given was if they had a PAP last year that was normal, but they're now on Medicaid this year and are not due for 3 years, how does that work if attestation does not pull into that? So I'll make a comment first, and then I want to turn it over to Julie Swearingen for just reiteration of the quality measures related to the contract with Medicaid specifically. So it's important to follow clinical guidelines and ensure that you're following best practice for when those things are due. And in that example, your EMR is the source of truth for that, which is completely appropriate. From the measure perspective, as it relates to the state, while we want you doing those things, there are a subset of measures that are actually tied to the contract itself that will be measured via claims. Julie, can you highlight those again?
Yeah, so for the VCO, what we're being held accountable for in the first year are those ED per capita and readmissions, and then diabetes A1C testing, breast cancer screening, and then the well child visits. As far as, obviously cervical cancer screening is not listed there, but I think breast cancer screening falls kind of in that same bucket of question there. And in this case, all of these measures require continuous enrollment. So in the example of breast cancer screening, if they're not continuously enrolled for 27 months prior to the end of the measurement year for that specific measure, they won't be included in the denominator. So that's kind of the plan's way, or the state's way, of making sure that we're not dinging you for something that you either don't have information on or you have no way to affect. I think I had something else on this and I've lost it. So if they have any gaps in enrollment, you won't be held accountable for that.
And then Julie, there's a follow-up question to that if they have Medicaid as a secondary payer, so the claim does not go to Medicaid because that's not who covered the service, how does that impact performance?
So I know that in this case, for at least dual eligible members, so dual enrollees with Medicare and Medicaid, they are not included in our VCO. I don't know in terms of if they have anything else and Medicaid. I know Medicaid is the payer of last resort, so we would certainly not get all of the information if they had a primary payer. I don't know, Steve, Drake, if you have any information on any members that maybe have a non-Medicare plan and Medicaid.
Julie, I may not be exactly correct on this, but I thought there was some discussion at one point in time relative to some supplemental files that may be available to submit such data to help you meet those measures, that you could take that information on those individuals and submit in that manner. But I know that creates some challenges because it is a manual process, both for you as providers submitting that as well as for the state and receiving it. But that may be an option that was discussed at one point in time. We could check on that as well.
Thank you. And Steve, I'd like to ask you a follow-up question more to the specifics of the Medicaid card. They're inquiring as to if the St. Luke's Health Partners VCO is listed on the Medicaid ID card. Do we have any updates on that?
No, it will not, to my knowledge, be listed on the card. It should be included in the VCO that the member is assigned to in your eligibility roster. I believe that is a field that is included there, and that's where the group would be able to find that particular listing for the member.
Thank you. Additionally, this question is for either Michelle or Dr. Necochea. We've received several questions. If the care management services being provided by St. Luke's Health Partners team will count towards the care management requirement for the tier case management payments from the state. Can you talk a little bit to that, please?
Thanks, Angelica. This is Michelle, and it will not count towards the state requirement. We will share information back, but we don't meet those criteria. We won't be filling that need or meeting your individual criteria for that.
Thank you. There's another question around well child visit claims, and I'm trying to interpret the question correctly. So it appears that if a patient has, as an example, Blue Cross primary and Medicaid secondary, they were told that they need to send $0 claims to Medicaid to count. Julie, do you have commentary on that, or is that a follow-up item?
I think that's going to need to be a follow-up item. So it sounds like we just have a couple of questions around what supplemental data, can be added or can we surface to the state to help close gaps And are there any additional things that need to be done on claims to make sure that those quality measures are satisfied?
Thank you for noting those. Additional question would be perhaps directed towards Steve. It asks about if the VCO info will now be included on eligibility requests per patient.
You know, I'm not exactly certain on that, but maybe something we could follow up on that. I'm trying to make certain I'm understanding the question, their eligibility requests. So
I think that might, and I'm taking a guess here, might be talking to when a patient goes to sign up for Healthy Connections, knowing who their eligible providers are that they can sign up with as a PCP, and then would it indicate the VCO information? So we can follow up on that.
Yeah.
All right, I am not seeing any other questions in the chat. I'd like to turn the time back over to you, Dr. Schott, to make any parting comments.
You know, I think, again, we just want to thank you for dedicating the time and taking the time to participate today. Hopefully, again, you've got a sense that we're fully committed to this. We may not have all the answers. There are going to be a lot of challenges down the road, but we're a partner with you. And we look forward to working with you all and getting to know you better. If there were questions that you didn't get onto the chat that you have, please don't hesitate to shoot us a note and we'll respond to those as well. And those couple issues that came up, we'll get back to you and as we connect with the state to get more information. So thank you again for all the time and have a good rest of your day. Thank you.